Thank you very much, and I'm excited to share this presentation with everyone. I put it together in a way to give people an idea of what neurosurgery is about. I've got a lot of slides to share with you, so I'm gonna jump right in here. So, as far as first becoming a neurosurgeon, just to give you an idea, after high school, of course, you have to go to four-year college. Then there's 4 years of medical school, 7 years of neurosurgical training. A lot of neurosurgeons then do subspecialty training, which can be an additional year or two. After that, you can get licensed by the state. You can apply to get board certified. And by that time, you're usually in your early 30s, and then you're starting work. After you do that, the work schedules is busy, and you have to continue to get education and stay up to date, attending meetings, and there's a 10-year recertification process. Me personally, I was born and raised in California. I went to undergraduate medical school at Boston University. I did my training at University of Pittsburgh, and I've been in Springfield since 1997, between Bay State and Mercy and Holyoke, and served most of the hospitals in the Valley since then. So I'll start first with a couple of terms. So commonly, a physician will say, well, I'm going to refer you to neuro, or we're going to consult neuro. And I wanted to point out the difference between a neurosurgeon and a neurologist. They're totally different fields of medicine, and surprisingly, we don't have a lot of interaction with them as a specialty. A neurosurgeon evaluates people for surgery. So when a patient sees me, the question in my mind is whether surgery is an appropriate intervention for this problem. A neurologist may deal with people that have multiple sclerosis, headache issues, medical issues of the brain and nerves, not the surgical side of things. When it comes to seeing a patient, the most important thing really is the patient's story and the exam. And the reason I say that is because everybody's scans, everybody's pictures are going to show something. And I wanted to spend a little time here because as patients have access to their medical records, this is becoming more and more of a point where they'll have an MRI and the impression will read something like this. And I'll read this out loud. It says, degenerative changes at multiple levels with a right-sided disc herniation at L3-4, L4-5, a left-sided disc herniation at L5-S1, clinical correlation suggested. Or another one might say multi-level degenerative changes of the lumbar spine as detailed above, including herniated disc, neuroforaminal narrowing, and stenosis. So a patient reads that, and commonly they get this feeling like they're really in trouble. They've got a lot going on. And I'm going to assure you that that's really not the case. So this is a study from 1990, and I'm just going to show you the abstract here. Read it carefully. It says that they took a group of patients, of people that never had low back pain, never had sciatica, never had neurogenic claudication. That refers to pain in the buttocks and legs with walking. And in the group that was 60 years old or older, 57% of those scans were abnormal. So just let that sink in a little bit, that people that have never had back pain, never had sciatica, a lot of those people have abnormal MRIs. So when it comes to evaluating a patient, the final point of that paper was there's a real danger in making a decision to operate just based on a picture without any clinical information. And what I do when I see a patient is I ask them in really simple words, tell me what's bothering you. If I, over the years, my style's changed a little bit. I start by saying, well, what are you here to see me about? And they say, well, I have a herniated disc. And in my mind, I'm saying, well, most everybody's got herniated disc, but what's really bothering you? So once you know what's really bothering the patient, then you can put it together with their scans. So pictures, ways of looking inside the body. Everybody's familiar with X-ray. So a CAT scan or a CT scan, so that stands for computer-assisted tomography. What is happening is that with the X-ray and a computer, you are reconstructing that and looking at slices of the body, almost like you put the body or brain in a bread slicer and you're looking at each slice. And we look at these backwards or from the feet up. So here's an example of a head CT, and let me just get my pointer out here so we can go through this a little carefully. Sue, can you see that laser pointer okay?
Yep.
All right.
Looks good. It looks
all right.
good.
So this is a scan, and as I said, we look at these upside down from the feet up. This is a slice of somebody's brain. This is actually the left side of their brain. This is the right side of the brain. I'm going to focus on the left side. This is normal. So the white here is the skull. This is the substance of the brain here. These are hills and valleys, gyri and sulci, the actual substance of the brain here. This is the normal side, and you can see on the right side, things look a little bit different. Now, a radiology report has to put this picture in words, and that's a tough job, I think, but a picture speaks 1,000 words. So when you look at this, you can say, wow, that's not right. You have this left side of the brain as your reference point. You can see, wow, I don't really see that CSF, the cerebrospinal fluid in the spaces, and the substance of the brain doesn't look quite right. And there's kind of this circular area here. That's actually a tumor. This is a tumor with swelling. So that's an abnormal CT scan. Second way of looking in the brain is with an MRI. That stands for magnetic resonance imaging. So our body has a lot of little magnets in it, and magnets have a positive and negative side. That's called a dipole. So when you put our bodies in a very strong magnet, all of those little magnets align themselves with the big magnet. When that big magnet's turned off and all these little magnets start spinning around randomly, that creates an energy field that magically creates a picture. So an MRI is a bit different than a CT scan. A CT scan is good for looking at things like bone or blood. An MRI looks at things a little differently. So let's look at an MRI scan. So again, we look at these upside down. This is a slice of the brain as if you put a head in a bread slicer. So this is the right side of the brain, the left side of the brain. The cerebrospinal fluid is dark. This is another important anatomical space. This is the ventricle. The skull here, calcium is actually black on an MRI. So this is the skull rather than that bright white. These nooks and crannies of the brain you can see. And on the left side here, not the right side of the picture, but actually the left brain, this person has been given some dye, and you can see this abnormality here, and the brain around it looks abnormal too. So this is swelling around a tumor or an area of abnormality. That's what an MRI looks like. Patients commonly get MRIs of their spine, and an MRI of the spine is pretty easy to read, and I want to show you how to read that. If you think of the spine as just a long hallway, this being that hallway, the spinal cord runs in that hallway, in your neck and in your thoracic spine, the mid-spine. And in the lumbar spine, you have a bunch of nerve roots. So this is that hallway. These are the blocks of bone that make up the back, this in between. This herniation is like the floor buckling up, and I'll show you some examples of that. So this is a normal MRI here on the left. You can see the one on the right is quite different. This is an 88-year-old gentleman, and that actually is pretty good. I mean, it's not a good-looking MRI, but functionally he's pretty good. So what matters is the patient and how they feel, not how the picture necessarily looks, but you can see the difference between this MRI on the right and the MRI on the left. So now to evaluate your own MRI, you just have to have this idea of what normal looks like. So far, the patient's been referred to me. I've examined the patient, and I put this in red now. We've received permission from an insurance company to get an appropriate workup. And I could do a whole talk about this problem of healthcare in the United States right now. So that's highlighted in red, and I'll move on from there. Then the patient and I look at each other, and I say, I think you need an operation. Well, now I have to get permission from an insurance company to do that too, even though, I've taken the time to become a neurosurgeon and get trained. Sometimes they don't let me decide for myself. But once we get past that step, we can schedule an operation and get into the operating room. And this process can take some time, and I feel bad for what patients sometimes have to go through to get through this process. Obviously, it's different in a life and death emergency, but sometimes in a more urgent or elective setting, unfortunately, this can take a lot of time. So here we are. The next part of this would be actually taking you into the operating room as best as I could. So a typical operating room, this is the bed that the patient would be lying on. This is the operating microscope we use. There's some whiteboards to keep counts and times. And then very important piece of machinery, the anesthesia machine. The anesthesiologist and nurse anesthetist would be here, various syringes of medication. That syringe right there with that white medication in, that's actually propofol, common medication, a ventilator, anesthetic gases, and then some monitors here. An EKG would be here, blood pressure, respiratory rate. This is what it kind of looks like in action. I'm missing the anesthesia part of it here, but the operating microscope coming over the top of the field. It's draped out, so it's sterile. Scrub tech with me here and instruments on an instrument tray. Some of the typical surgeries that a neurosurgeon will perform, and we'll go through some video of these: anterior cervical discectomy, posterior cervical surgery, lumbar discectomy, aneurysms, tumor surgery, some other things that involve radiation. So I'll move ahead through these so I'll have some time to talk about particular operations. So very common is surgery of the spine. So why would someone need an operation for the spine? So one would be for pain. A person has significant pain. They've had physical therapy, they've had chiropractic care, acupuncture, injections, yoga. There's a litany of things that people try, and then surgery might be appropriate to help them. Sometimes people come with significant neurologic findings. Their spinal cord's not working right. The term myelopathy refers to the spinal cord being injured, or they have a foot that is weak, or they have perhaps weakness in the thigh. There's a big difference between a foot drop, weakness in the foot, and weakness in the big toe. So we use kind of the importance scale things to decide what's worthy of an operation and what might not be. And psychosocial factors also come into play in dealing with patients. And an anterior cervical discectomy is a common operation that we do when discs in the cervical spine herniate, causing weakness or injury to the spinal cord. And the person has either significant neurologic problems or they didn't improve with physical therapy. Back to this picture here of a normal spine. So on the left here, I've put an MRI of a normal spine. Someone's imagine split right down the middle. This is the spinal cord, this gray ribbon running in this long hallway, blocks of bone that make up the neck, the discs in between. So use this left picture as a reference, and you can see on the right here, there's something quite different. So the curve of the spine, this is a normal curve here, like a gentle C shape. This curve is the other way. Right here between the fifth and sixth bone of the neck, you can see this piece of black blob sticking out in the spinal cord. That's a herniated disc, like the floor buckling up. The address of this is numbered by the bones of the neck. So this is the cervical, this is the second cervical bone, C2, third cervical bone, C3. So the disc space between C5 and C6 is labeled C5-6. So this is a C5-6 herniated disc. I showed you some slices of the brain. This is a slice of the neck. And now you're looking at cross-sectional anatomy. This is the disc. This is a normal level. The spinal cord here. And you can see where it's abnormal. This disc is blown out towards the spinal cord. It's putting pressure on the spinal cord. And that's a problem. And this gentleman had a problem. So somehow my predecessors of neurosurgery found out that there's a magical way from getting out here in the skin, right by the carotid artery, right by the trachea and the esophagus, right down to this disc. And it's a magical freeway right there from here to here. Sometimes we just get to in a few minutes in a nice little plane that looks like this. So here is a really quick video of what an anterior cervical discectomy looks like. So we're looking down on the spine. I've cut out the disc here between the bone. We're looking at the spinal cord, the covering of the spinal cord behind there. I'm tapping a block of bone in place as a spacer, and then securing a metal plate, titanium plate with 4 screws. That disc space, the bone getting tapped in. There are various spacers that can be used. And this is what it looks like when we're done. So we've replaced that herniated disc with a block of bone and a metal plate. So that's called an anterior cervical discectomy and fusion. An alternative, and one that I'm using a fair amount, but it depends on the particular case, is an artificial disc. So similar operation where you have to cut out the disc to make room, but rather than putting a block of bone and a metal plate like I've put over this person here, these are artificial discs that allow movement of the neck. And the principle or the theory is that so when you have a fusion, your neck still moves, but the strain is put on these unfused segments, which can wear out a little bit prematurely. Then an artificial disc, in preserving that motion, would tend to decrease that adjacent level wear and tear. So this is an artificial disc insertion rather than a fusion. Sometimes it's more than just a disc. So this unfortunate gentleman had a process in his body that completely eroded 2 bones away. So you can see there's this huge angle. This is a CT scan, but this angulation to his neck, this bone is really moth-eaten and corroded. You can imagine his spinal cord in that hallway just being draped and pinched over that. So this person needed what's called a corpectomy. Corpus, the body, you're removing these blocks of bone, the body. Then after I've removed all that space, we've got to put some supporting structure in there. And that's this supporting structure. So a big strut of bone, a long titanium plate to hold it. And because it's such a long segment I had to do, I had to supplement that with fusion construct from behind. So that would be an anterior cervical corpectomy. In some cases, we can approach the spine from the back and avoid a fusion. Disadvantage for that, it's a little bit more painful going through the back of the neck, but it has some advantages too. I'm going to move along quickly. I do have a lot I want to show you, so get to the more common things. Herniated disc in the lumbar spine, very common. Sciatica, shooting pain down the leg, or weakness in the leg. Now, many times people will get better with time. Time is a big healer for things like this, but if time isn't working, sometimes surgery becomes appropriate. So this is so I'm looking through the scope. This is the nerve root here, the edge of the nerve root. This is the disc herniation here. So I'm just gently pulling the nerve root away, and then with a small scalpel, now this is quite magnified. This is a small space. This is maybe a 2 millimeter suction in my left hand. And then I'm going to reach in with some grasping forceps. That's a pretty big disc herniation, and that's a much more happy nerve not getting pushed on. So that's what a lumbar discectomy looks like. Fusion. So fusion's an important operation when used properly. It, I think, may have been overused in the US over the last 20 or 30 years for some problems, but let me show you a few situations where a fusion is absolutely necessary. So fusion involves joining 2 or more bone segments to form a single unit that doesn't move. And in the process of a fusion, we may put bone in, various substances that help grow bone, like bone morphogenic protein, and usually metal screws, plates, and rods to hold the whole process, the whole structure together. So here's a few examples of where a fusion or a problem that may think of needing a fusion comes into play. So one is malalignment. You can see these blocks of bone here lined up, and here this block, the edge of this bone is offset from this bone, and there's some narrowing in that hallway. So if we're going to put this together and hold it there, that might require some structural support. This gentleman here, this is an X-ray of his neck. You can see his chin is basically on his chest. He had lost enough supporting structure from the back of his neck that he was basically walking around with his chin on his chest. Another situation would be destroyed bone. I showed you this picture before. And finally, fractures. So here, again, the hallway, but something's not right up here. You can see this peg of bone has been cracked and knocked off and is pinching on the spinal cord. This is the brainstem here, the cerebellum. So very high up in the cervical spine, this person has a fracture of the neck. Fusions are important. Here's an example of the reconstruction. This was the person that had his chin on his chest. We did a 3-level anterior cervical discectomy, which is not common, but he needed quite a bit of support. You can think of it, I've jacked up the front of the neck and then added some support from behind. In this fracture here, this is an odontoid fracture. The odontoid is the process sticking out of the C2 vertebral body. In this case, once I got the fracture in alignment, I put a screw right down the middle of it to hold that together. That's an odontoid screw. In the case of this situation, which is very common, so this bone slipped forward on this bone. This is L4, L5. This is called spondylolisthesis. This is an L4-5 spondylolisthesis, along with some narrowing of the hallway. So that narrowing is called stenosis. We're going to open up that space and put these bones in alignment. So there's a spacer between the bones and some screws with a supporting rod holding that in alignment. So that's a fusion of the lumbar spine. Another common problem that neurosurgeons face, and more so in the past, and I'll briefly touch upon, are aneurysms. So an aneurysm is a blister off a blood vessel, and I'll show you a picture of what that looks like. And the problem with an aneurysm doesn't come from them just sitting there. Many people have aneurysms, very common in the population, but the problem comes when an aneurysm ruptures, and that can be a life-threatening event. A person that has an aneurysm rupture will complain of the worst headache of their life. We'll see the blood on a CAT scan, sometimes a lumbar puncture. This is what an aneurysm looks like. This is a map of the blood vessels in the brain. So this is a catheter that's been threaded up into the carotid artery, and then some dye shot through. This is the internal carotid artery as it snakes through the skull base. Here it enters the part of the, this is a segment of the carotid artery called the cavernous sinus. It gives off the ophthalmic branch here. And right here, you see this circular bubble right at the base of where the posterior communicating artery comes off. This is a common aneurysm called a PCOM aneurysm. And this aneurysm had ruptured. At CT scan, we have to remember what the normal looked like. This quite doesn't look normal. You can see this faint white filling the nooks and cranny, the CSF spaces of the brain. That's a subarachnoid hemorrhage, bleeding in the subarachnoid space from a ruptured aneurysm. So this gentleman here on the left, Ghazi Yazergil, is one of the pioneer superstars in modern day neurosurgery. He taught really the neurosurgical world how to operate under the microscope, the approaches to clip aneurysms. He designed many of these aneurysms, and clipping an aneurysm across the neck. Here would be this artery, the blister off the side, clipping the aneurysm off the neck was the only way we had until more recently, when catheter technology improved, where now aneurysms can be treated with coils or stents, very much like in the heart. So the doctors can come up with a catheter and put coils up in the aneurysm and prevent the need from an open surgical operation. So these are the treatment options in modern day neurosurgery for an aneurysm. So now we'll switch to the brain. Common term, craniotomy. So otomy, we're opening, going to make an opening in the cranium, craniotomy. So this is a brief video I took today of a craniotomy. I'm holding in my right hand a drill that spins at 72,000 RPM with a little foot plate. I've got a suction in my left hand. I've made a little hole here that I can put that drill in. And what I'm going to do is just swing this around. So incision through the skin, down to the skull, a little hole in the skull called a burr hole, and then using the Midas Rex drill to turn a bone flap. And once you connect the dots, you can lift that bone flap out. And that's a craniotomy. So little opening in the skull, and this underneath then is the covering of the brain called the dura mater. So that's the term craniotomy. So that's just the very beginning parts of an operation to remove a brain tumor. So brain tumors, they come in all kinds of different shapes and sizes and different locations. This was a patient who had a tumor, not very large, but in a really bad spot. This is the pituitary gland. This is his pons, midbrain, right really in the center of his head. This is a better picture. You can see his nose, his tongue, the back of his head. The tumor was here. And the trouble it was causing, it was pressing up on his optic nerve, and he was losing his vision. So after I did that bone flap, a little bit different shape and location than the one I just showed you. This is the optic nerve here. I'm cutting the covering around it because it was constricting the nerve. Then I'm taking that same high-speed drill with a different bit and drilling out that canal to remove this constricting waste on the optic nerve. Once I made some room around the optic nerve, I could start attacking the tumor. The tumor was sitting between both optic nerves. This is the right optic nerve, the left optic nerve, the tumor here. This is an ultrasonic aspirator that pulverizes the tumor and sucks. I have a suction in my left hand. The right carotid artery is here. So through these windows, there's a window here, there's a little window here. I've opened up that optic canal so that the optic nerve is safe, and that's removal of that tumor. So we'll go back to that slide. So he had this tumor here. Now you can see it's gone. That was removal of that tumor. Now, tumors, like I said, come in different sizes. This is a really big tumor. This is a slice of the brain. You can see on the left side of the brain, this huge tumor, that ventricle, that butterfly that I showed you before, pushed way over to the right. And this is the MRI after the tumor was removed. And in time, this will all come back to mid-position where it should be. This is a tumor that was right smack in the middle. You can see this was a tumor called a meningioma, as were the last two actually. Little purplish tumor here. Tumors can also present in the spine. So again, I use this hallway analogy a lot. You can see the hallway here, and right here, there's this white ball just filling the hallway. This person was really weak because this tumor was squashing the spinal cord. And this is what a spinal cord tumor looks like. So it's within the dura, the covering of the brain and spine. So I've opened the dura, and it almost looks like a sausage link here sitting, filling that canal. So that canal, the hallway, the width from there to there should be a nice, happy spinal cord sitting in the middle of it. Instead, you got this big sausage sitting there. So the techniques for that, again, this ultrasonic aspirator, I'm going to debulk the center of the tumor. And after that center of the tumor is debulked, I can, it doesn't have that mass to it anymore. I can delicately peel it away from the nerves in the spinal cord. Then after we're all done, you see a nice space where that tumor used to be. Problem that I have some experience dealing with because of where I trained. I'll spend a little time with, even though it's an extremely uncommon and very rare problem. It's a horrific problem for a patient to have, and that's trigeminal neuralgia. Trigeminal neuralgia is known medically as the suicide disease. It's one of the most horrific, painful conditions that a person can experience. Worse than kidney stones, worse than childbirth without anesthesia, worse than traumatic amputation. It's this horrible lightning bolt of pain in the face, usually triggered by brushing the teeth or washing the face or even cold wind hitting the face. And it's caused by, in most cases, a blood vessel hitting the nerve. And that whole concept now we take for granted, but way back when, this was really a crazy idea that a blood vessel touching a nerve would cause such a horrific problem of pain. Another problem caused by a blood vessel irritating a nerve is spasm of the face. So when the blood vessel hits the facial nerve that controls the face, people get this involuntary facial spasm. And the person that really showed the world this was Dr. Jannetta, and I was fortunate to train under him. He was a magnificent chairman, and really has a lot of students of neurosurgery out there that just love him. He passed away in 2016. He helped a lot of us. There are many current chairmen that trained with him, but he was the one that really showed the world and pioneered the techniques to treat trigeminal neuralgia. He initially came up upon a lot of criticism from the community because it seemed to be such an outlandish idea, but he was proven to be right, and this is the treatment of choice now for people with trigeminal neuralgia. So the Jannetta procedure, this is a brief video of the Jannetta procedure. You have to imagine that the patient is on their side. This is an incision marked behind the ear. So this is behind their right ear. And we put these little pledgets of Teflon between the artery and the nerve to separate it. These are just on a tray. I'm working under the operating microscope now, exposing around the cerebellum. We're going to take down this blood vessel that's kind of in the way of getting to the trigeminal nerve. The picture, unfortunately, is not 3D, so the depth I'm working at here would probably be about 2 3/4 to 3 inches from the surface of the skull down deep. This is the trigeminal nerve here, this artery that was in front of the nerve, pressing on the nerve. So what we do is lift it out of the way and put these Teflon pledgets between the artery and the nerve, so that artery is happy, and that cures people of this horrible problem. When it's spasm of the face and the facial nerve, little different compartment. This is the vertebral artery deep, the posterior inferior cerebellar artery, and this is the facial nerve making a bend right at the brainstem there. This artery took a right angle turn, and right at that elbow was pinching the nerve, causing this horrible spasm. So we lift that artery out of the way, stick that Teflon in that face, that space between the facial nerve and the artery, and that patient's cured of hemifacial spasm. Pituitary tumors, another medical condition that a neurosurgeon would face. Pituitary tumors, the pituitary gland sits really in the center of the head. This is nose, back of the head. This is the space of the pituitary gland. This is a huge pituitary tumor. And what we do here is go through the nose, and you can see right through the nose gets you right to that tumor. So no incision, a little work through the back here of the sinus. This is an X-ray view of some of the, this is just a nasal speculum. So I can look back there, a suction, some curettes, and I'm working in that space of the pituitary tumor. Some of the modern technological advances that have allowed us to do surgery even better is frameless stereotaxy. It's a very important tool now in the operating room. It's a computer-assisted localization tool that helps us be precise to about 1 millimeter, and it allows much less invasive direct approaches to lesions of the brain. The way it works is this. So this is in the operating room. This is like the satellites in space. It just works like a GPS system. These satellites in space track these balls on this pointer that I hold in my hand, and I can then put that on a person's scalp and pinpoint exactly where the tumor is. We did not have this in the early 90s, mid 90s. We would have to make these huge craniotomy flaps to find tumors. Now we can go down, point right over it, and make, you can see, if you were doing this as a neurosurgeon, you could make a precise opening right over that and go shell that tumor out. This is an amazing tool that we use regularly. And this allowed another very important tool that some people will have come in contact with, called radiosurgery. So rather than operating and cutting tumors out, for brain tumors that are less than 3 centimeters, so this is a little bit more than an inch diameter, for people that have tumors of the hearing nerve called acoustic neuromas, for people with malformations of the brain, even in some cases of trigeminal neuralgia, there are tools called the Gamma knife or Cyber knife or X knife that deliver a very high dose of radiation. And here's how it works. There's a radioactive cobalt source that's guided through these collimators. Each one allows one beam of radiation, but these are all focused on a particular point. So you can imagine that point right there is getting a very, very high dose of radiation, whereas these single beams are not producing a lot individually. This is a frame attached to the patient's skull. So that point can be put in a particular location and for lack of a better term, zap a tumor. This is Dr. Lunsford, Dave Lunsford. He is one of the pioneers of radiosurgery. He brought the first gamma knife to North America at the University of Pittsburgh, and has done thousands and thousands of patients and helped really set some of the recipes and treatment algorithms for radiosurgery. So you can see this patient lying. They have a skull frame attached, and they're going to go into this gamma knife unit. These are the collimators that focus the beam. This is the stereotactic frame that's affixed to the patient's skull. And this has revolutionized patient care. Many tumors and lesions that previously we would have to operate on, we don't have to now with the advent of the gamma knife. So other cases that a neurosurgeon would do, carpal tunnel surgery. Sometimes we're asked to do muscle and nerve biopsies because people have a problem with their muscle or nerves, and the neurologists are trying to figure out what might be wrong. Sometimes bleeding in the brain, sometimes shunts, which is diverting spinal fluid from one location to the other. And unfortunately, here at Bay State, a level 1 trauma center, we see a lot of trauma, head injuries, falls, car accidents, violent trauma, etc. So that's a bit of a run through of what a neurosurgeon does. Sue, I hope I didn't put everybody to sleep, and open to answer any questions that might be out there.
For me, that was fascinating. I can't believe your expertise in technology, what you're doing for patients. Amazing.
Thank you.
Well, thank you for your time. We do have a number of questions, so we'll get to as many as we can. I know you're on call, so I know we need to end on time as well. So the first question is, what are the psychosocial considerations for surgery?
So that's a really good question. And Sue, before I get to that,
oh, sure,
I'm trying to figure out how to stop sharing this. You said, but I'm not.
You're
able
all set.
to.
You're
all right, all right, good. Okay, so,
what are the psychosocial considerations for surgery?
So that comes into play very importantly when we're operating on people that have issues with pain and pain alone. We clearly, and this is not a bias on my part, we clearly know that issues like depression have a factor in how people do after surgery for pain. So I would say depression is a big factor. Patients' family, the help they would have at home to get care for after an operation. I think in other instances we have to be cautious, and this is again a little bit of the nuance. You have to be cautious sometimes of secondary gain issues. If people are involved in a litigious situation with competing groups of lawyers involved, car accidents, that can be touchy. So that is a very high altitude view of what some of the psychosocial issues that come into play when surgery is being considered.
Great, thank you. The next question, how far down the spine does a neurosurgeon operate?
I'm sorry, how far down?
Yes, how far down the spine does a neurosurgeon
What
operate?
the entire spine is in the realm of what we handle. So that would include the cervical spine, the neck, the thoracic spine. So to get more into the detail, there are 7 cervical vertebrae, there are 12 thoracic vertebrae, there are 5 lumbar vertebrae, and you have the sacrum or the tailbone below that. That's all under the realm of what we would deal with.
Thank you. Are you operating from the front or back of the patient?
Depends. So anterior, front, posterior, back. Tumors, if the tumor is in the front, the approach might be with the patient lying on their back through the frontal lobe. If the tumor is in the back of their head in the occipital lobe, the patient may be face down on the operating on the operating table.
Thank you. What are the movement limitations on a patient who gets a fusion?
Oh, excellent question. And surprisingly, so when patients have let's say, like the person that is in horrible pain, has a large cervical disc, they're commonly splinting and not moving so much. So even though I would do a fusion and technically I've eliminated motion at one area, they'll commonly say afterwards, "Oh, doc, my neck feels so much better. I can move it so much better now." So physiologically, by X-ray, we're eliminating a little bit of motion, but in real terms, people don't notice it. In fact, they feel like they have improved motion. Now, if someone is having a very long segment fusion, and I didn't get into that, like some people with scoliosis, or they have a fracture where they have many segments of their spine fused, well, then they're going to have very, very rigid spines and have limitation in movement.
Thank you. Are patients awake for any or some procedures?
Yes, they are.
Hmm.
So that's the short answer. The long answer is, well, there's some operations where with anesthetic techniques, you don't have to be put to sleep. Like carpal tunnel, that's about a 20-minute operation for me. So with a little anesthesia and a little sedation, patients are comfortable. They don't need to get a breathing tube for that. Some of the techniques I use for trigeminal neuralgia with a needle, I didn't get into, but those are done awake with sedation. And sometimes with brain tumors, if brain tumors in a critical location, so skin hurts, and that's about it. The brain doesn't feel pain, even though the brain is the substrate that actually, quote unquote, feels pain. The brain doesn't hurt when you touch it. So once a patient would have their skin anesthetized and a bone flap turned, they would comfortably be able to be awake while we poke and prod in the brain. And that's where you could check if you were hurting somebody's speech or motor function.
Good, thank you. Are there known risk factors for brain or spinal tumors?
Oh, yes. So in general, I, I think in terms of common risk factors, what I would tell patients, so in terms of anesthetic risk factors, an untoward event of, say, death. So 1 in 750,000 to 1 in a million people are going to have an untoward, unexpected complication from anesthesia. Extremely rare. More common complications, infection. Infection rates are very low, on the order of 0.5% to 1%. Injury to the spinal cord, that'd be very rare too. Now, certain situations, a higher risk than others. If I'm taking out a very large meningioma, a very large tumor of the brain, where a lot of the critical arteries involved, there's a 10% chance I'm going to hurt that person with injuring an artery that causes a stroke. And that's just the nature of the operation. That's not because I made a mistake. It's just because arteries can get wrapped up and get caught and be involved with a tumor. And sometimes they get injured. Sometimes they go into spasm after the fact. So with large tumors of the brain, you might have a 10% stroke rate.
Thank you. The next question, how does adding plates relieve compression in trigeminal surgery? Seems counterintuitive.
So no, the plate, no, in the Jannetta procedure, the artery impinging on the nerve is the cause of the problem. We're moving that artery away from the nerve and putting a little piece of felt between the artery and the nerve so the artery doesn't press on the nerve anymore, and that relieves the pain. There's no plate there.
Okay, thank you. How do you determine level of radiation for gamma knife? Size spaced? Can you see the tumor shrinking as you apply the beam?
Yeah, so excellent questions, but wrong specialty. So radiation oncology handles that.
Okay.
So Dr. Lunsford, Dr. Flickinger, and some other groups around the country, based on the volume of the tumor, that's where dose gets determined. And I don't know much more about that besides there's recipes for the amount of dose that certain tumors get.
Very good. Well, you have excellent expertise, so that's totally fine. Well, this is a great comment. First of all, wow, 3 exclamation points. Dr. Kalia just distilled 50,000 hours of training and another 50,000 hours of experience into 45 minutes. Well done.
Thank you.
There's a follow-up to risk factors. I meant, are some people more likely to have a tumor of spine or brain? Lifestyle choices.
Excellent question.
Yeah.
Yeah, I think the next generation of physicians will have a lot more answers with that. There's so many tumors we see that we don't know why. Everyone kind of figures out or knows now that smoking causes lung cancer. But when it comes to other tumors of the brain, no, we really don't know why. Now, I think as they get a better understanding of the genetic mishaps and DNA mishaps that cause tumors, the next generation of physicians will figure that out. But at this point, we really don't have an answer.
And it looks like that is the last question. We'll just give everyone just another minute if there's anything else, and we're close to time anyway. But really, I applaud you for the great videos and the presentation you put together. Fascinating.
Thanks, you. I'm glad, and I'm thankful for people to spend some of their evening looking at neurosurgery. So thank you.
And the last comment is thank you. Enjoyed it and learned a lot. So thank you for your time, Doctor.
All right. Take care. Have a good night, everyone.
Thank you.